Introduction to Traumatic Brain Injury by Dr. Lisa DelSignore.
Hi, I'm Lisa DelSignore. I'm one of the critical care fellows at Boston Children's Hospital, and today we'll be talking about neuroprotective strategies for managing increased intracranial pressure in the setting of traumatic brain injury.
Principles of Traumatic Brain Injury.
So first we're going to start talking about some of the principles of traumatic brain injury. And typically what we think about is you're going to see this in the setting of some type of traumatic mechanism. So whether or not this was a high-speed motor vehicle accident or some other type of non-accidental trauma, you will likely have some type of traumatic mechanism that is the cause of the brain injury. And you may see things like skull fractures or cranial deformation, or you could see things that are more subtle, such as just intracranial bleeding that perhaps you see on an infant who had a head CT for irritability or extreme lethargy. And in the setting of this, you might see things like epidural hematomas, subdural hematomas, subarachnoid hemorrhages. And the thing to think about is if you get a story where you don't have a traumatic mechanism to explain these findings of intracranial bleeding, to always think about non-accidental trauma in your differential diagnosis. And the reason for this is these types of bleeding can occur from having rotational or torsional injuries in which a baby is actually shaken back and forth, such that the brain gets compressed against the bony prominences of the skull and can lead to some bridging veins that tear and have bleeding into the intracranial space in the forms of the hemorrhages described. The additional finding that you can see in severe brain injury includes diffuse axonal injury, in which the white matter is injured. And typically this happens quite frequently in children compared to adults. The thing to know about traumatic brain injury is that all of the types of injuries we're talking about right now in terms of intracranial bleeding and diffuse axonal injury are often primary injuries that we see. However, our management in terms of brain injury really focuses at preventing some of the secondary injury that can happen when the brain starts to swell after having a primary injury. Typically, peak swelling occurs within 2 to 3 days post-injury, and what we see is this type of mixed edema form in which we have a vasogenic component in which the blood-brain barrier has been disrupted. And then we also have a cytotoxic component in which cell necrosis has led to an increased osmolar load that also contributes to additional swelling in the brain.
Intracranial pressure versus cerebral perfusion pressure.
In talking about our management, we are really going to be focused on trying to decrease the amount of swelling that we expect the brain to have, and also target our therapies to prevent ongoing hypoxia or ischemia that may act as a result of this increased swelling. So the first thing I'd like to talk about is the principles behind brain swelling in terms of the Monro-Kellie Doctrine, which you may be familiar with. Essentially, this doctrine states that the cranial compartment is incompressible, so the volume inside is a fixed volume. There are 3 things inside the cranium that make up its volume: brain tissue, blood, and CSF. Because the volume is fixed, these 3 things maintain an equilibrium such that when the volume of one component increases, the volume of another decreases. For example, when a lesion such as an epidural hematoma adds to the brain volume, there are compensatory decreases in CSF and venous volume, as you can see here. However, at a critical point, the CSF and blood buffers are not able to compensate for changes in cranial compartment volume. That is, when the volume increases too much, usually at volumes greater than 100 to 120 mLs, the intracranial pressure begins to rise as well, as you can see here. At this point, the intracranial pressure begins to skyrocket with changes in intracranial volume. And what we're trying to prevent here is reaching that critical point where brain swelling increases so much that the intracranial compartment is unable to maintain its pressure. And this is important because the amount of intracranial pressure that we see is directly related to the cerebral perfusion pressure, which is the driving pressure the brain is seeing in terms of delivering oxygen and other key nutrients to it. And cerebral perfusion pressure is defined as the equation, as you can see here, mean arterial pressure minus the intracranial pressure. So for any constant mean arterial pressure, you can see that as the intracranial pressure starts to rise, your cerebral perfusion pressure starts to drop, which means that the brain will start to see less nutrients, less oxygen, which can have deleterious effects on the brain in terms of ischemia and cell death.
Update. The 2019 Brain Trauma Foundation guidelines for management of pediatric severe traumatic brain injury recommend a minimum cerebral perfusion pressure of 40 with a recommended target range of 40 to 50 to avoid going below 40. For older patients, a target higher in this range may be used.
And typically when we talk about managing cerebral perfusion pressure, we think about minimum targets by age. And we'll get into this in a little bit in a few minutes. But you can see here that less than 4 years of age, we try to target a cerebral perfusion pressure around 50 millimeters of mercury. Anywhere between 4 to about 10 years of age, we target around 60 millimeters of mercury as a minimum target. And greater than 9 years, we start to think of them more as like an adult and target cerebral perfusion pressure around 70 millimeters of mercury.
Cerebral blood flow versus cerebral perfusion pressure.
Next, I just want to talk about the relationship between cerebral blood flow and cerebral perfusion pressure. Knowing that cerebral blood flow is going to be what's actually delivering nutrients to the brain and is separate from cerebral blood volume. However, if you have an increasing cerebral blood flow, you will likely have an increasing cerebral blood volume, which will also potentially increase your intracranial pressure. But you can see here the concept of autoregulation in the brain, in that along a wide range of cerebral perfusion pressures, your cerebral blood flow stays relatively constant until you hit the extremes, either on the left side of the curve or the right side of the curve, where the brain is unable to compensate. On the right side of the curve, you can think of this as the cerebral perfusion pressure is so high that now the cerebral blood flow just astronomically starts to increase due to overwhelming volume. And on the left side here, you can see that as the cerebral perfusion pressure drops between a critical level, your cerebral blood flow drops dramatically as well. And we can think about this in the setting of ischemia and probably putting the brain at a high risk for hypoxia and cell death.
Factors that affect cerebral blood flow.
So I like to talk about a couple of factors that in particular affect cerebral blood flow. One of them is the oxygen content in the blood. And you can see on this graph here that at a normal PaO2, which would likely be somewhere between the 75 and 100 range, you have a relatively normal cerebral blood flow, which is anywhere between about 40 to 60 milliliters per 100 grams per minute. As the oxygen tension in the blood begins to drop, closer to the 40 range, you start to see a large increase in cerebral blood flow. And effectively, that's the blood vessels in the brain vasodilating as the brain is sensing that it needs more oxygen to function. And so you get a large increase in your cerebral blood flow, and consequently your cerebral blood volume is going to increase, and likely in that setting, if you already have a brain that is swollen, your intracranial pressure is also going to increase. And this will become important when we start talking about some of the variables in management of traumatic brain injury. Another factor that affects your cerebral blood flow is the concentration of carbon dioxide within the blood as well, measured as a partial pressure. And you can see here a normal partial pressure of carbon dioxide in the blood is going to be, on the arterial side, is going to be anywhere between around 40 to 45 millimeters of mercury. And likewise, you can see that your cerebral blood flow here is also at a normal range, around 40 milliliters per 100 grams per minute. As your carbon dioxide level in your blood begins to rise, you can see that your cerebral blood flow also increases. And again, that's largely an effect of the pH and level of acidosis in the blood that causes the blood vessels to vasodilate. Again, vasodilation, increased blood volume, increased cerebral blood flow probably will exacerbate any ongoing intracranial swelling that is there. As you can see on the left side of the curve here, where below a partial pressure CO2 level of 40, the blood vessels in the brain experience vasoconstriction. And once you get to levels below 30, the cerebral blood flow decreases to a point where the brain is at increased risk of ischemia. I just want to draw your attention to this figure as well, which I think is important to realize that there's a portion of management in traumatic brain injury where we may have some ongoing reversible deficit that we're starting to see up front, and we're trying to prevent this from becoming permanently infarcted brain tissue. And what you're seeing here is across the x-axis, ischemic duration in hours, and on the y-axis, again, you're seeing cerebral blood flow. And what you can see is at a level that is about 18 milliliters per 100 grams per minute, you start to see ischemic effects that are potentially reversible starting to take place in the brain tissue. And the longer that the cerebral blood flow is at this low level, you start to see permanent infarction over time. And I would say at a level of about 18 milliliters per 100 grams per minute, around 4 hours is probably the time period you're going to start to see some permanent infarction. Likewise, if you start to have lower cerebral blood flow up front, as in somewhere around 10 milliliters per 100 grams per minute, you're actually starting to see these effects become more permanently infarcted more quickly than at the higher reduced cerebral blood flow. And so it's important to think about things that are going to put your cerebral blood flow at an appropriate level, keep your cerebral perfusion pressure up without increasing your intracranial pressure to hopefully prevent any permanent infarction from this traumatic brain injury.
Stepwise management of elevated intracranial pressure.
So that takes me into thinking about how we actually manage strategies to lower increased intracranial pressure, prevent further ongoing brain swelling. And again, going back to thinking about the brain as sort of being in a fixed box, there's two ways to think about this. One would be there are strategies we can do to lower the intracranial pressure, such as some stepwise medical management that we'll go through, or surgical options such as placing a ventricular drain that could actually drain CSF out. Or we could employ strategies that are actually going to increase the intracranial vault size, something like a decompressive craniotomy where we're actually taking a piece of the skull off to let the brain swell out. We're not going to spend a lot of time talking about that today. We're going to focus mostly on talking about stepwise medical management and draining CSF out to lower the intracranial pressure. So here you can see is a stepwise medical management of traumatic brain injury that has been developed here at Boston Children's Hospital. And we're going to go through this step by step. So here you can see on the base of the pyramid are going to be strategies that we'll employ up front. And as our brain injury worsens or we're unable to decrease the intracranial pressure, we're going to take steps up this pyramid and employ additional management to try to decrease the intracranial pressure. So I think the first principle to think about is targeting what is, quote, normal, and that a lot of our therapies up front are going to be avoidance of things that we know are going to exacerbate the brain to utilize more oxygen, utilize more nutrients, increasing its cerebral metabolic rate. We kind of want to keep the brain in a sort of low level functioning of normal. So one thing we're going to think about is temperature management, and we want the patient to have normothermia, so a temperature that's around 36 to 37 degrees Celsius. We're going to avoid fever. We're also going to target things like normal glycemia, as we know the brain utilizes glucose for energy, and we want to not have the glucose level be too high. If so, we would give the patient insulin, and likewise, we wouldn't want the glucose to be too low, and in that case, we would give a little bit of glucose back. But right up front, we're typically going to give the patient normal saline containing IV fluids without glucose or dextrose in them and continue to watch the glucose levels and treat them as needed. The other thing that we like to target as normal upfront is blood pressure. So going back to our cerebral perfusion pressure equation, in which the mean arterial pressure minus the intracranial pressure is going to give you your cerebral perfusion pressure, we want to make sure that we have an appropriate mean arterial blood pressure to perfuse the brain in order to make sure that our cerebral perfusion pressure is at an appropriate target. So typically we target mean blood pressures that are going to be normal for age, and if that, about the 90th percentile for age and height based on the age of the child. Oxygen is another piece that's important that we talked about earlier and how it relates to cerebral blood flow. So again, we want to avoid hypoxia, and we're going to target normal oxygen saturations. And we'll talk about some ways that we can manage that in a couple of slides if you have an intubated patient. Carbon dioxide we also talked about previously and its effects on cerebral blood flow. And again, we like to target a normal range between 35 and 40 millimeters of mercury. And typically, we're going to try to avoid hyperventilation in this instance, because as we demonstrated on our graph before, how carbon dioxide affects cerebral blood flow, we don't want to drive the PCO2 down to a point where we're now seeing effects from ischemia in the brain, causing further secondary injury. And again, to manage the PCO2, it would be very difficult to do this, obviously, in an awake and breathing patient. So we're talking about this mostly in the context of having an intubated and ventilated patient, where we can follow their blood gases closely and their end-tidal CO2 and manipulate their ventilator as needed. And we'll talk about this in a couple of minutes as well. We also like to avoid hyponatremia, as we know that sodium is an important component and decreasing swelling in the brain. So what we will do is we target a sodium level that's between 140 and 155 millimoles per liter. And again, this is important to prevent ongoing swelling in the brain. CSF drainage is another component that we can talk about. It's sort of the next that we would do up front if the patient had ongoing hydrocephalus or increased amount of CSF that's contributing to our swelling. Typically, we're going to need a neurosurgery consult for this, and actually EVD placement can be performed at the bedside, and it really serves a dual purpose. So an EVD is an external ventricular drain, which means that the catheter is actually placed in the ventricular system, so it can drain CSF out, but it can also transduce an intracranial pressure. And typically, we're trying to target an intracranial pressure less than 20 millimeters of mercury. You may have heard of other types of intracranial monitors, such as parenchymal monitors or bolts, which can be put in other areas of the brain. However, they can't actively drain CSF. So if your goal is to actually decrease the intracranial pressure by decreasing the amount of CSF there, then you really need an external ventricular drain to do that. The next thing to think about on our stepwise pyramid would be to think about things that are going to decrease the cerebral metabolic rate, or the amount of energy that the brain actually needs to function, and kind of keeping the brain at a very low level of functioning. And essentially what we would do is try to increase the amount of sedation that the patient is seeing, and potentially even think about things like neuromuscular blockade. Again, you will probably already have an intubated and ventilated patient at this point. But using things like morphine and midazolam drips for sedation and neuromuscular blockade, such in the form of vecuronium or cisatracurium, would certainly decrease the amount of metabolic demand on the brain. And that would sort of be the next step in our pyramid here. If you're still seeing increased intracranial pressure and decreased cerebral perfusion pressure after maximizing our sort of normal goals for the brain, our sedation, our paralysis, we would probably think about other targets to increase the mean arterial pressure to increase your cerebral perfusion pressure. And again, we could use things like vasopressors, such as norepinephrine or dopamine, to increase the mean arterial blood pressure. And what we are trying to do by using vasopressors is to actually avoid giving more fluid. As we know, giving too much fluid will probably exacerbate some of the edema that's already there. Next on our pathway is the consideration of hyperosmolar therapy. And the goal here is really to create an osmolar gradient that is going to draw fluid out of the brain. And there's two ways to do this. One is through the use of mannitol, and the other is through the use of hypertonic saline. Hyperosmolar therapies work by increasing osmolarity in the blood, creating a concentration gradient between the edema, or excess water, in the cerebral tissue and the blood. Hypertonic saline and mannitol are effective because they do not cross the blood-brain barrier, and thus they promote movement of fluid along a gradient out of edematous brain tissue and into the bloodstream. So typically mannitol, we're going to think about using amounts of 0.5 to 1 grams per kilogram aliquots. And how mannitol works is that it is essentially like giving a large sugar into the brain. It's going to decrease your blood viscosity, and it's going to cause a diuresis. So it's important to think about giving a fluid bolus when using this therapy so that you don't have an extreme drop in your mean arterial blood pressure that may also then decrease your cerebral perfusion pressure. We typically like to use hypertonic saline to drive the sodium levels up to the 155 range if normal saline is not getting us there. And this can be done by using different concentrations of hypertonic saline. So again, we typically use 3% hypertonic saline, but there are formulations such as 7.5% or 23% that are used in the adult world. You can give this as a bolus to initially just boost up your sodium. The way I like to think about it is 3 cc's or 3 mLs per kilo of 3% saline will raise your sodium by 3, just as kind of a rule of thumb. And typically, if you're going to give this long term, as you can give it as a continuous infusion, it's really important to have central line access to do this, as giving a osmolar load of this type through peripheral veins over time can cause some damage to the peripheral vasculature. If we're still having increased intracranial pressure despite all of those prior medical management, and we are seeing other deleterious effects in terms of cerebral perfusion pressure, we will start to think about employing mild hyperventilation. What I mean by mild hyperventilation is that we may consider targeting PCO2 in the 30 to 35 range as opposed to the 35 to 40 range. And really, any levels lower than 30, we start to see an increased risk of cerebral ischemia or stroke and permanent neurologic infarction. Additional things that we can do to decrease the amount of cerebral metabolic demand from the brain is to put the brain into a deeper level of sedation using pentobarbital or propofol. Typically, propofol is not on our pyramid, and we say to sort of use this with caution for long periods of time, as there is the potential to develop propofol infusion syndrome. So for that reason, we often think about pentobarbital if we're going to have days and days of a patient on this type of continuous infusion. And again, with pentobarbital, we're really trying to target burst suppression and keeping the brain at a very, very low level of functioning. So when we have pentobarbital on board as a continuous infusion, we'll often have EEG leads in place as well, monitoring the brain waves. And the important side effects of pentobarbital to keep in mind is that it can give you a pretty profound hypotension, so you may need to go up on your vasopressor requirement in the setting of this use. And additionally, over time, it is a myocardial depressant, so just to keep in the back of your mind with your intubated patient that they may see some mild effects related to their cardiac function in the setting of prolonged pentobarbital. So after thinking about pentobarbital, that really takes us to sort of the maximum therapy on our pyramid here. And at that point, we've essentially seen refractory increased intracranial pressure. So I just want to take you back to our pyramid one more time so you can get an overview of our pyramid here. And hopefully managing traumatic brain injury aggressively up front may preclude us from needing to go stepwise up this pathway. But at times we do see refractory increased intracranial pressure that requires these higher therapies. So with that, I thank you for your attention.
Formal notification of the appropriate Child Protective Service agency is indicated in all cases of suspected child maltreatment. Involvement of the Child Protective Service agency will help ensure the future safety of the injured child as well as other children and siblings who may be exposed to the alleged perpetrator or perpetrators. In the United States, it is required that all providers file a mandated report if child abuse is suspected. Please help us improve the content by providing us with some feedback.